Great. So today's session is brought to you by HCD International and BlueCross BlueShield of Illinois. I want to thank both of those teams for pulling together today's session and look forward to the content. So I believe we are going to start with the video. So let's go ahead and roll the video.
No life can be better. I'm really trying. I want to be my best. I just had a baby and I have diabetes. I was released from my job. I'm facing eviction. My car is down. And yes, I need food. What do I do? I need some help. I gotta get to my doctor. I gotta raise my child and get back to work. Can you help me?
Good, good afternoon, everyone. I'm Suzanne Latang. I'm a clinical strategy manager here at Blue Cross Blue Shield of Illinois, and I'm joined by my co-presenters, Ms. Jean Drummond from HCD International, Ms. Deidre Sherman, Chief Customer Officer from PS2G, and Mr. Ravi Sankar, Senior Partner at PS2G. Our topic today is shifting from the traditional to transformational care, reimagining roles and strategic partnerships within the MCO to deliver high-quality outcomes. Next slide. We're excited to go over our presentation objectives. This collaborative presentation will demonstrate the results-driven impact of shifting the role from the traditional MCO and redefining it to meet modern population health challenges, creating buy-in both internally and externally to deliver high-quality outcomes in a transformational care model, and building agile partnerships with community-based partners and trusted organizations to collaborate on an integrated approach to amplify population health strategies for improved health outcomes. Next slide. What you'll see covered today is before strategic partnerships, a disjointed member experience within a complex system, as demonstrated by the video that we opened with. Blue Cross Blue Shield of Illinois, I will cover the movement from traditional to transformational, embedding intentionality throughout a strategic population health and community engagement approach. Then we'll have our partner PS2G discuss the power of collaborative partnerships for sustainable community interventions. And our additional partner, HCDI, the impact of using quality outcome lens to build strategic interventions on the ground by employing the parachute model. And we'll finish with demonstrating how after strategic partnerships are deployed, it strengthens the member experience and enhances health outcomes. Lastly, our call to action, how we can make an intentional impact and a new perspective on ROI. Next slide, please. So to begin, Blue Cross Blue Shield of Illinois is a managed care plan that a health plan and managed care plan that serves 800,000 members across the state of Illinois for Medicaid. We're the largest commercial insurer in the state, covering approximately 8 million lives. Our team at Blue Cross Blue Shield is very committed to improving access to care and reducing disparities across all 102 counties because these communities are where our members live, where our coworkers and families live, work, play, and learn. Prior to 2018, we covered for Medicaid, Cook County, which is where Chicago is. And in 2018, the Healthcare and Family Service Division expanded the managed care program to cover all counties in Illinois. This program is member focused and it's called Health Choice Illinois. Throughout that contract, we serve a diverse population of members, including urban settings in Chicago and other cities across the state and rural populations alike. Our membership characteristics include our highest enrollment that we have is in the population between 1 and 15 for both males and females. So we have a lot of youth and family interventions. And then our densest population for the plan is in Chicago, located in Cook County, and we have a little bit over 300,000 members in Cook County. For this contract, it does require that Blue Cross Blue Shield use in good faith efforts an amount equivalent to 20% of our administrative dollars each fiscal year on state certified diverse owned organizations. We call those organizations BEP organizations, and the partners that are on this call and presenting with me today are two of our BEP vendors that have helped us to collectively have a stronger impact in the communities we serve. The contract also requires us to focus on population health, implementing quality improvement methods to reduce health disparities, and focus on interventions within disproportionately impacted areas. And those will be referred to as DIA areas and zip codes. Next slide, please. So starting with what is population health? Population health in our team really looks at health outcomes of a group of people. This can be people that for a certain social group, a certain economic group, environmental. We could be looking at behavioral factors. We are trying to improve the health of that entire population by addressing health disparities and promoting access to resources. Who is included in a population? The population is defined by a shared characteristic. It can be geographic. We could be looking at it from a city lens, from a zip code lens, from a county lens. We could be looking at it through health diagnoses if we're trying to deploy an intervention specific for diabetes, hypertension, behavioral health, even maternal health. We can look at it through a healthcare provider. So we can pull all the members that are assigned to a healthcare provider and really do a deep intervention with that provider group. Additionally, we can look at other groups such as ethnicity, employees, or individuals returning from a carceral setting, or individuals with living with disabilities. Key aspects for population health really to control the risk factors. We need to identify those high risk groups. It might be those with certain vulnerabilities. Um, Related to behavioral health, related to substance use. It could be individuals that are returning into the community settings from a carceral setting. We want to really be cognizant when we're putting out health education campaigns to the population that we're serving. So we've heard from our different communities that they prefer a flyer to be coming in a community setting at their church, in the grocery store, at the library. They don't want a phone call. So really being cognizant of what population you're serving with the health education campaigns that you're distributing to make sure that it matches the population you're trying to reach. We can look at this as community-based interventions, where we really focus in a community-based organization to deploy intervention, or screening and early detection. Underneath all of the factors that impact population health are non-medical drivers of health, and you can see that is related to our healthcare access and quality. It's related to economic stability and our neighborhood and overall environment that individuals live. Next slide, please. So within our team, we understand that health disparities exist because of structural historical systems that drive inequities. As we try to disrupt those, we really want to develop interventions that are multi-level, that are really leveraging existing partnerships we have within government programs, and also developing new partnerships together to have a collective impact and really close gaps of care. We do this across many different systems outlined by the circles on the screen. At the biggest circle is the environment, and looking at the government relations that we have, participation on boards and stakeholder groups and trade associations to really have an impact on laws and policies that affect the systems in which everyone operates. We then look at organizationally, what partners do we have within our BEP programs that we can work with to strategically impact the members, whether it's local politics. We work here in the city of Chicago a lot with our local aldermen to help us ensure that we're reaching all the constituents in that specific area. We work a lot with business resource groups internally that have a specific focus, whether it's individuals that are veterans or individuals that are of a certain ethnic group, to really engage those populations that we're trying to reach. We work largely with different fraternities and sororities to engage their membership and help us with spreading the word within different populations. We also will look to our communities and really want to be intentional with our community partners, whether we're looking at churches and faith-based groups, and utilizing those spaces to connect with members, places where our members are already naturally going. It might be partnering with a WIC grocery store because we know our members are shopping there, and we want to be able to bring programming into those spaces that members are already at to make it an easy, accessible program that they would benefit from. We look at interpersonally. Should we bring together a group initiative, or should we bring together a partnership that would allow for both a mom and their kids to participate in? So we've done some family cooking classes where both our member and their children are able to come together and learn the healthy benefits of eating fresh produce, learning about how that can impact their health condition. It can also be individually deploying web or app tools that promote healthy behavior change. A lot of the digital remote monitoring partnerships and vendor solutions that we've done are really utilizing technology to impact and assist the member with their health goals. We might need to deploy member incentives to help the member either with gas to get to an appointment or incentivize them to participate in a program. And lastly, we also want to make sure that we're always thinking through health literacy and digital literacy and making sure that whatever way we're educating our members is appropriate to the population we're serving. So every time we're deploying a new initiative, we're looking across all these different systems and activating any and every lever across these systems to have the best collective impact over time. Next slide, please. So sustainable intervention programs require a both and, looking at our traditional and the transformational strategic approach that we really want to disrupt and dismantle health disparities. In a traditional program model, it's really looking at how do we get this intervention to scale as quickly as possible and to be able to not just have it in one area of the state or in one market, but to move it across the state, across populations. It's also really looking at single vendor partner solutions, going deeper with one partner, the ROI, and really what the ROI looks like in terms of money and the cost savings for the company, and also how we can generate revenue from the intervention. While all the things are definitely important, I want to keep them in mind. The transformational strategy, we're not only keeping those in mind, but we're looking to start small, really focused pilot strategies with community partners that know the communities, that are invested in those communities, and working with those community-based organizations or other minority-owned businesses in our BEP program to really impact a small focused group that we can show and demonstrate change. And that demonstrate change might not just be in return of dollars, but it might be addressing those non-medical drivers of health barriers and resolving those through these partnerships. It might be bringing on multiple partners, such as you'll hear on this call, that we like to impact every lever by bringing in different partners that can really address different parts of the disparity that we're trying to address. We want to be acknowledging the use of technology and predictive analytics to help us really make sure that we're pulling in the members that are the most appropriate for the intervention. And with predictive analytics, we can really take a list of 1,000 members appropriate for a housing program, for example, and see with the predictive analytics who would be the most beneficial from both, understanding that member's needs, but also a cost perspective. But we want to make sure that we are using this technology to help us also find the members most appropriate for our program the most efficiently versus a manual process. As we do see cost savings, we really want to make sure that we're reinvesting in the communities that we're serving and the populations that we're trying to address, and using those dollars to build capacity with our partners like those on the call with me today. And as they help us with addressing the populations that we're trying to reduce the disparities, returning those dollars saved back to those organizations to build capacity to reach even more. And lastly, making sure that we're having a multi-layered vendor community partner collaboration. We want to make sure that we're not just doing that single vendor partner and having one partner solve all of the aspects of the initiative, but really layering in multiple different partners that can help us with all those different levers across all the different systems that was on the previous slide. Next slide, please. Our food as medicine approach is an example of how we've looked at the traditional and turned it into transformational. We really look at our vision for food as medicine as a multifaceted, sustainable approach really addressing the wide range of food insecurity that our members experience. Currently, our food and medicine program is for pregnant and postpartum. We have several different programs that are going for pregnant and postpartum, including home delivery and also a food vault that members can come and pick up their own produce. We have senior programming related to both home delivered meals through a couple different partners that I'll go through here shortly. We have food as medicine that is assigned for individuals with chronic conditions such as hypertension, diabetes, obesity. And then we are also using our Food as Medicine program for community engagement through monthly food pantries that are held at our Blue Door Neighborhood Center and open to the community and Blue Cross members alike. At those events, we're also providing food literacy information so that we can provide nutritional information to address some individuals' chronic conditions that can be improved with healthy, fresh produce. The individuals listed in the blue boxes, Daja Health, Dion's Dream, Growing Home, and T. Castro, are four more of our BEP vendors that are really focused on helping us reduce these disparities when it comes to food. Saja Health is a vendor that provides culturally intelligent meals to our birthing persons and their families during pregnancy and postpartum. These are culturally relevant. They're selected for each individual family based on family size. The participant gets to pick the meals that are most culturally appropriate for their lifestyle and their home. And these are home delivered for up to a year postpartum. Dion Chicago Dream provides fresh produce delivery to some of our senior members and also has a food vault program that you see in the pictures below. In that program, we are able to provide 125 families a week with a fresh produce box. In that program, they also receive support for nutrition and dietitian through another one of our vendors, VHP. So we are providing that nutrition and dietitian counseling in addition to fresh produce to help address chronic conditions such as hypertension and diabetes. This is also for members that reside in food deserts. So we're looking at that population health data to help us identify food deserts around to deploy these food solutions. We're also working with a local urban farm that's located in Chicago, and they have not only fresh produce that's grown right in the city of Chicago, but also a workforce development program that allows for individuals residing in the Inglewood neighborhood of Chicago to learn job training to be able to help on the farm, but then also get long-term jobs outside of that program. The produce that is grown at Growing Home is then also delivered to seniors that live within food deserts in those disproportionately impacted areas. And lastly, we use T. Castro as our food fresh produce vendor. They provide all the fruit that you see in the boxes below, the boxes that go into the food vault, and additionally at a lot of our community events across the entire state. They provide pop-up farmers markets, help us with different programming, lots of back to school festivals and youth programs that we deploy all across the state all year round. And with that, I'm going to turn it over to Ms. Deidre Sherman, Chief Customer Officer at PS2G, to talk a little bit more about our collaborative efforts.
Awesome. Thank you so much, Suzanne. That was an amazing overview of all the many programs. And it's just a partial list of all the programs that Blue Cross Blue Shield offers in Illinois and across the country. But when we think about building successful programs for you as a partner, we think about really what does transformational mean? As we started having this conversation some time ago, traditional versus transformational, we really thought about what would be the differentiator. And for us, it's about sustainable. So it's not just creating events or creating a experience, it's about creating a continuity of experiences through your programs and integrating with existing programs that you have today. So I'm going to talk a little bit about what a successful program looks like and how we get there. From a programmatic standpoint, we're going to talk about a couple of examples. And then we're going to talk about how we measure ROI. And I know Jean's going to talk about that as well. But for us, it starts with goal setting. I am a Stephen Covey person. I like to begin with the end in mind. And we sit down with BlueCross BlueShield as our partner to really talk about who do they want to reach? What are their goals and objectives? What are the outcomes that they're looking for? It's very difficult to have a meaningful conversation in this space without at least talking about outcomes and what do those outcomes look like. So as you go into a program, we're really setting the tone for who are we looking to reach? And once we reach them, what do we want to accomplish? What changes do we want to see in their health, their healthcare experience because of this engagement? We look at both internal data to the health plan as well as external data. And that view of the data is really to inform us, who is this population that we're about to engage with? What are their ages? What are the demographics? What are the things that might be important to them to understand? And how will they receive that information? Suzanne mentioned it being culturally intelligent. And that's important to us because if it is not culturally intelligent, we're going to miss the mark. So as the vendor who might be providing the service, I'm also going to engage local partners because that's very important to breed and bring credibility to the program, that people can see folks from their community. So county executives, state programs, affinity groups, faith-based organizations, FQHCs, people they see in their community all the time, that will help build our credibility. Partnering with these team members and expanding our team with these team members is a key element to our success. These team members, these expanded team members, allow us to define what community context or community intelligence is about. Not everyone will receive the information the way we intend it, or will receive the information the same way. So by building some understanding around who's in this population or community and understanding how they will receive it by engaging these different partners, we're able to build curated experiences that will cover a multitude of groups. And there's different planning methods to do that. That's sort of event planning management. But really the focus here is to try to make sure that the message is hitting home and that it's being received in the intended way that we're trying to send it. I'm going to talk about the people only from the perspective of fun, because it's important to make the engagement or the programs fun and to introduce a little bit of the human factor, if you will, associated with with the engagements. You're going to find that people are going to be far more interested if the experience is varied. They're going to be far more interested if there is a draw to the event. So you've got to explain to them what's in it for me, that experience. And then finally, I'm going to touch on ROI. Jean's going to talk about it a little bit more. But for us, the ROI is about the investment to sponsor the event, but the ROI also includes healthy outcomes for those members. So from the event or the activity or program, you want to follow those members that are participating in the program. You want to follow them for a couple of reasons. One, you want to find out if it made a difference. But you also, most healthcare programs have a plethora of programs that a member can participate in. It would be almost impossible to pull the right program at the right time without some support. So we offer that level of support to understand exactly what their needs are. In the vignette we saw at the beginning, we saw a mom who had just had a baby, and she may not know all of the services that the health plan can offer. So the idea is to create a bi-directional communication with those members post the event that will allow them to take the most advantage of the program. Next slide, please. This is what a community profile, engagement plan profile looks like. So it takes into consideration the demographics of the area. It looks at that population, it looks at race, it looks at their age, it looks at how many people are employed in that area. So it's going to take into consideration, and we have excluded from this profile the health plan data because that is a little more specific than we wanted to be, but publicly available information we've included in this profile just as an illustration. From this profile, we learned there was a pretty high or significant rate of the people that are in the target population that are employed. So included in this particular event, we looked at including a job fair because there are some people that are not employed but might have an interest in being employed. And for those folks that are employed, the number one topic on my weekend is about work-life balance. And I think almost everybody is looking for that because we're trying to do more with less. We also think about the type of outreach that we'll do. Is it a huge event? Do you rent out an amusement park? Do you do something that's individual? You don't want to lose the people in the largeness of the event. So when Suzanne talked about transformational, she talked about small and then scaling. We want to scale, but we never want to lose that personal curated touch that ensures that the member feels like they're not communicating with some huge organization that will get back to them next month, but is responding to them very quickly. So that's all part of not only having an engaging event, but a very successful event is building on the event occurred. Now, how are we going to touch base with you after the event? How are we going to follow you? And also, how are we going to make sure that you get all of the services that you need? Next slide, please. So we have a couple of different engagement models depending on what we're trying to accomplish. We do large community events or do a series of events. We also look at service activation. Service activation is really more about activities that we do to ensure that a member understands all the services that are available to them. So if you do live in a food desert, and we've identified you as someone living in a food desert, we're going to give you some information and options and education around how you can get to healthy foods. We were fortunate enough to participate in some of the community events around food deserts and preparing foods in a healthy manner. We can send you all the fruits and vegetables we want to, but if you're frying them all, we still have an opportunity or a gap to close. We do digital experiences, and that's primarily through SMS text. And then finally, we deploy community health workers for that personal touch when it seems more appropriate. And that largely has to do with acuity of the individual and perhaps those that might have behavioral health concerns. So we look at that individual as well as the total population, and we activate the different engagement models based on that. The next slide is really just an illustration. Thank you. The next slide is just an illustration of what some of the programs that we've done. We've done workforce enrichment programs. We've done summer youth programs that focused on reducing violence. in other areas. Suzanne mentioned the Food as Medicine program. We also run a program out of our Washington, D.C. office that can be attended live and in person or virtually. And it is a workforce infrastructure program that focuses on testing as well as cyber security. And we've listed some of the wonderful partners that we have utilized to bring these projects and these programs to life. I'm going to turn it over to CJ, my partner, just to talk about community partner scorecards. CJ?
Thank you, Deidre. So as Deidre mentioned earlier, when we look at the programs, the initial analysis is also to look at outcomes. So look at outcomes in the sense, what is it in it for, what should we be measuring on the back end? And one of the first things that we look at is what are the change in utilization for some of these members that go through these programs. So they've experienced, they might have a barrier, there is a social intervention, and then is there a change in their outcomes? Is there a change in their utilization pattern? So the way that we are measuring outcomes could be whether there is a change in the utilization itself, if there is a reduction in ER visits, or it could be some clinical outcomes. It could be a variety of measures at the individual level that we want to be able to measure. We want to see the effectiveness of the outcome itself. The second thing we want to do is we also understand like members are different. There could be some high risk members, there could be some low acuity members. So you want to be able to adjust these outcomes for member risk. So already BlueCross BlueShield understands the different types. They have already risk categorized their members. So we are able to look at the outcomes from a member risk perspective. Then the third thing that we do for a community partner is also understand their capacity for core services. If they are providing a core service, what is the capacity that they have? Are they able to take service 50 meals a day? Are they able to do more? The housing capacity could be any of that. So what is that capacity for the service that they have? And the last is, as the members go and receive these services, go through these interventions, what are their satisfaction levels? Because ultimately, like there is a experience factor to all of these services, social services that get delivered. And what we have done is created a composite scorecard with these 4 factors, so that you're able to look at your different partners and evaluate them and see if there is any feedback you want to provide them. Also improve on the ones that provide or have higher scores on the scorecard. With that, Ms. Drummond, over to you.
Great, absolutely. Thank you so very much. And I'm excited just to share a little word about our organization, and certainly want to say thank you so much to BlueCross BlueShield Illinois, Suzanne, for allowing us to participate with you. We've been working probably about the last 5 years and supporting much of this great work. So HCDI, we are award-winning population health and advisory management organization, clinician-led. My background is as a clinician. And we have worked with CMS for over 22 years. And so that really gives us a bedrock of understanding federal, state, and local policy. But more so, what is how do we really transform the entire healthcare continuum, from the policy to the patient to the provider practice, really? And how do we really move from the traditional to the transformational? And so when we think about policies, we think about, how does it actually, when you're working with your networks, when you're working with community-based organizations and community-based practices, right? What are some of the challenges that they may face in the rural areas or in the urban areas? Our work is really engaging member populations, whether they are in rural areas, in urban areas, in suburban areas, wherever they may be across the country. But particularly, we're working with health plans after they have already begun to work with their populations. And so we get the hardest of the reach, the unable to reach. Or so we think those members that may, just not have the trust in the systems. And so we're working with government-sponsored organizations, employer-sponsored Our work is national. We've had the opportunity of working in every state in the country, and we are high trust. So we have over 50 million different records. And so how do we really bring this together to support plans such as, Blue Cross Blue Shield of Illinois to really drive to the goals that they have? And so it's very customized. We can go to the next slide there. And so when we think about that organizational workflow and we're approaching a plan, it's all about what are the needs of that plan's members and how do we identify them? How do we do some predictive analytics as well as understanding what is the current state of their members? What are the goals that are identified in their state contracts? And so we are working with the MCO to refer the member to community partners in their community, right? That there's trust. We want to leverage that already historic and established trust. We want to support them in their HRSNs or their non-medical, drivers. How do we get food? We want to develop that relationship before the transaction with the member. And so oftentimes, if we are addressing those concerns, as Deidre has said, that's very important. We have a community hub that connects that member to ensure all of those needs are met. So it's not just a 180, but it's a 360. We want to come back to that member so that we can ensure your CAP scores are increasing and, your member experience is improved. You don't have member abrasion. And then ultimately creating that continuous feedback loop. Something that worked in January may not work in April and certainly may not work in December. So how are you measuring your outcomes? If we can go to the next slide. So what is the methodology that HCDI uses? And I walk, if you see me, you're always going to see me with my, with my lens here. And so that's very important. So why are we doing it in the first place? When we think about our parachute methodology, it is typically driven by either the data, there's data that you're looking at, and you're looking at data from a multiple lenses, your quality improvement data, your care coordination, your member services. You're looking at multiple sets of data and triangulating that data to ultimately understand what is the root cause of this particular problem. Or is it a state mandate that says in your contract? Is it a recent policy procedure? What is the driver or cost? Let's say, maybe I know some time back, we looked at, with CMS, or you're looking at your claims data and you're seeing that you have an unusually high percent of members that are going into the emergency room or the inpatient. So what is the root cause there that you might find? I know some time back, we were working with an organization and they had a number of children who were going to the emergency room because of bronchospasm. Well, we found out there was a rodent infestation and parents were utilizing the roach bombs at night when the windows were open. And so we developed a campaign called Kill the Bug and Not the Child. So sometimes it's very important as you bring that data together. Who should you be serving? Well, are you trying to address childhood immunization? Are you trying to address chronic disease management around diabetes and hypertension, as again, Suzanne mentioned with the food boxes and how we're delivering services, making sure that it's the right intervention for the right population at the right time, right? So how do we leverage maybe the children going back to school around immunizations? And so how do we maybe leverage getting mammograms for women during maybe Mother's Day? And so how do we just bring those, a number of activities together that are important? Where is the population? So are we talking about zip code in North Carolina 28725, or are we talking about in an urban area, which is in Detroit? So Statesville, or, what we're doing there, which is a area near Charlotte, it's very different than maybe 60619 in Inglewood. So how are we really making sure that we are thoughtful about the resources that may be available? And then what are we doing? The interventions must be what we call geographically. I think I heard Ravi speak and Deidre, they must be geographically pertinent, culturally intelligent, as well as medically. So if we're trying to reach an older population, what you would do for a 15 to 18-year-old female, it's going to be quite different than what we're going to do for a male that is 40 to 45 years of age. And so just making sure that those approaches are relevant, intelligent, and then we've got to monitor. And I tell you, in our work with Blue Cross, sometimes something may last 3 months, it may last 6 weeks, it may last 6 months. We're constantly changing and looking at the data. Suzanne is saying, Jean, is it moving? Are people picking it up here? Maybe they're saying they don't want to pick up the food, in this location. We need to change it to that location. And so it's very important that you just don't do it and leave it. You got to come back, because ultimately, we want to drive cost-effective interventions that are going to lead to improved outcomes. So we can go to the next slide there, and that indeed we have ameliorated the root cause. So we are blending, if you're hearing our conversations of what Suzanne and Deidre and Ravi are saying, we're blending the quantitative data. So we have the claims, the pharma data, the demographic data. So we understand the utilization data, but we're also incorporating the qualitative data. What's the voice of the member? What are they saying? Sometimes we're thinking we're in one lane and no, it's not, that's not the reason. That cab driver was not nice to me and he said some things that were inappropriate. I'm not going to that post-op visit. Well, what happens to the plan? You end up getting an ER visit. Right. So I believe last time I looked in Illinois, if I'm not mistaken, the cost of a ER visit was about $1,800. Well, if that keeps adding up, think about that. When you get to the root cause, you could address it and lower those costs. We're all about lowering the costs and ensuring that there is quality of care. So how do we examine the names behind the numbers? There's people. The young lady that spoke earlier. That's our community. What does the member speak? What do they say? Guess what? Recently, we were talking to some members and they were telling us that their doctors were a no-show. Well, I don't know, back in the day, my clinical day, we would always say the member was a no-show. Well, if the doctor doesn't show up or cancels their appointment or has no availability to see them, from their perspective, they feel like they are shut out. And so there's a no-show. And so then certainly when we go into the communities, as Deidre kind of laid out, we look at the community as an asset, not a detriment, because people live there. There is a heartbeat there. Are you feeling it? Are you feeling that heartbeat in the passion? One of the things about HCDI and this entire team is we bring a passion to the work. It's not about checking a box. Okay, we called the person 3 times and they didn't answer. No. If a plan gives us a name, that person existed. Now, did they go out of state? Did the mother lose custody and now they're with a father in another state? Did they die, unfortunately? Where is that member? Are they in jail? Are they, incarcerated? Where is that member? And that's our job, to do our best. And they may be in the graveyard, hopefully not, but we're going to try to find them. So with that in mind, it's so very important that you identify the resources that are in that community. It might be a food bank. It might be, we were in Mississippi, we were on the Mississippi Riverboat. It might be Kennedy King. Suzanne, remember when we worked with Kennedy King College in Inglewood. So what are the resources? Change your glasses. Look at things as, maybe the dollar store could help us, or maybe even a car dealership. Think about it. Somebody's trying to buy a car. They got to sit in a, area for trying to get financing. And yes, our Medicaid members do get cars. They got to watch a television and can get them. How do we get information? Social media. So really thinking transformational, not the tradition. So as we move forward here, we got to monitor that data. Remember, I told you Suzanne is constantly looking at us. Jean, are we moving the lever? And so this is a dashboard. This is just an example of a dashboard of how we're bringing back and saying, we're moving we're collecting the data, but how over time we're able to change, is there the same difficulty of buying food? Now, I'll tell you, our mindset is we kind of want to, Suzanne, I hope you're not upset with me saying this, kind of work ourselves out of a job. Let's help people to become, let's engage them, let's educate them, let's empower them to move out and to activate, to be activated so that we may not have to make as many calls. And so we want them to get their jobs and to be able to buy food and to, be able to afford housing. And so these are some of the data that we're constantly watching on a real time. Was the member referred to resources? Did they receive those resources? What are the resources that they need? I know one time we found an area that there had been a fire throughout. So we look at ourselves as being your eyes and ears on the ground, in the community, not afar off. We even like our diction to sound the same. When we're in Mississippi, we're not bringing somebody that has a northern accent. That matters, and it erodes trust or either builds trust. And you only got one chance to make it, to help to drive that. So what I'd like to do is, Suzanne, Deidre, and Robbie, if you don't mind, let's go back and let's hear if we've been able to have an impact on our member that we value so much. Erica? Can you bring in the voice?
Afford a new place, but I didn't have any money to put anything in it. So he told me that he could connect me to places that give out furniture and clothing and food banks. And I was amazed because like I said, I'm a single mom. A lot of the things that I do on my own, and I don't get any help. I didn't have to ask for it. I didn't have to seek it. It was just provided to me out of the blue. I could have missed out on this opportunity, not thinking, I would have hung up on him. He connected me to a care coordination that, was able to provide me long-term help.
Absolutely. All righty. So we want you to know that this works. When you have, the intention that Blue Cross and Blue Shield and that all of their partners bring. Thank you so much for the questions. There is a real stringent requirement that the plan takes us through to make sure that we are ready, that we have the capacity, that we understand the community that we're in, and we're bringing individuals from that community. And so when we talk about ROI, oh yeah, yes, it is the money, but it's so far beyond that as well. Think about opportunities of cost reduction. So when we ask, where are you spending? What are the top 3 areas that you're spending your highest dollars? Let us look at that data demographically, geographically, yes, racial and ethnicity matters as well, but also understanding, are there any other, I love the question that we had about asking, is there physical impairment? Is there visual impairment? Are they physically, I like to say enabled, not challenged, but they have a different way of hearing and moving and what have you. So how do we bring that appreciative inquiry approach to what we're doing? When we're thinking about the money, yes, we want to, if there are any incentive dollars, if there are any other bonuses or things that plans are able to get. Yes, we are mindful of that. But are we also mindful of sustainability? Have we enabled this community to stand on their own, to no longer need what we call a hand up, not a hand out, to allow them to really create community sustainability? Because at the end of the day, none of us want patients to stay in the hospitals. because, obviously the high cost there. And so when we think about how we are engaging the members, engaging them in a way that they can stand up on their own, giving them just what it is that they need, not something that you want them to have. So that's very important. How do we, when we think about health disparities, oftentimes, we think about it in a very narrow way, but there may be a disparity. I think Suzanne mentioned it earlier, in cost. There may be the disparity in utilization and access. So how do we mitigate that and disrupt that? We need disruptive thinking in order to really move us to the level of sustained transformation that is truly going to reduce our national burden around healthcare costs and truly improve the health outcomes. We need members that are in the community. Oftentimes, community-based organizations have the heart, but they may not know how to collect data. They may not know how to submit a claim so that they can get paid. So how do we improve their sustainability to truly empower them so that maybe day one, we're in the front, but day 90, they're in the front. They're leading us, they're guiding us, they're telling us the intelligence. These are some return on investments that we must consider in that financial equation. Yes, we know about MLR, and yes, we know ROI, but how do we really build communities so that they are sustainable? And again, closing those care gaps, lowering the ER costs. That does come back to ensure that, your cost, that you can, maybe drive more preventative care rather than curative care. And certainly, again, here I'm saying, improved feelings of empowerment, like our patient that we allowed you to hear her voice. It's data-driven, it's member feedback, and it truly is a way that we can move to the next level. So as we close, we can go to the next slide here. Just a few takeaways that we would love for you to move away. So we want you to leave in action. We gotta get to work right now, right, Suzanne? We gotta get to work, Deidre. And so how do you shift your MCO thinking? How do you need to redefine what you're thinking about your members? How do you give them some tools so that they can then really be activated and participate in shared decision? So what's one thing? I was going to ask you for two, but what's one thing at least that you can walk away from and share with your management, or that you can really begin to integrate into the work that you're doing now? How do you get buy-in? Who is that person? And it's not necessarily the person with the title behind their name. It could be the person that's really from the community that understands this is the way we can transform. This is the way we look at things. This is what we call it, right? Let's think about our language. I think I heard Suzanne speak about the language and the importance of literacy. It's not just health literacy, it's community literacy. It's how do we build those kinds of, that kind of trust? And so that we can, deliver on quality outcomes, and then building those agile partnerships that can move, that don't have to do it the same way all the time, and really realizing. So when we were in Mississippi, we were on the Mississippi Riverboat. Gene, what? Okay, have you lost your marbles? No, I haven't. But why in Mississippi? Because everybody was going there, Deidre. I mean, on Friday night, Robbie, that's where everybody was going. So guess where we were? To get members, that had diabetes, to move into our diabetes self-management programs. And so, as we close out, we want you to know you've got to go where they are. You've got to understand, listen, go beyond the data of the numbers and look at the names. I'm telling you, they will help you to save money, and you will have better outcomes. And who knows, get that contract again with the state that you are so desperately seeking. So thank you so very much. We really appreciate all of the questions. And so I just want to say, please put your phone up, use our QR code, give us some feedback. We want to hear from you. We got a whole lot more work to do. Our country is in need of transformation and us working together. So I want to say too, on behalf of Suzanne at BlueCross BlueShield Illinois and Deidre at PS2G PS2G and Ravi at Sagittech. Thank you so much for allowing us to share a part of your afternoon together. We appreciate it. And certainly, Suzanne, is it okay? Any questions? I see a few you've been answering away. I'll turn it back over to you, Suzanne. Thank you.
Thank you, Jean and Deidre and Ravi, for all of your great information and sharing how we've all partnered together to have a collective impact on our communities, both here in Illinois and across some of our other states that HCSC works in. We did try and answer the questions as they came in. Thank you for, I think the last few things I've seen have been some comments of different programs that are happening in different areas of the country and some suggestions on different trainings for ASL. So thank you for all those suggestions and all the questions. If there's any additional questions that we haven't been able to answer or conversations that you want to have with any of us, please don't hesitate to reach out to Jean, Deidre, Ravi, or myself and provide any feedback via the QR code.
Yeah,
Otherwise,
great.
thank you so much for joining us this afternoon.
Sure. Suzanne, I also want to say thank you to you and your leadership for allowing us to have a voice and to do this work that we're so passionate about, because without your leadership and your organization, we wouldn't be able to make the impact to do this creative work, because it is different. So thank you so much.
Thank you.